Today I will be discussing the treatment of acute alcohol withdrawal in hospitalized patients. My name is Elizabeth Harvey and I am a PharmD candidate class of 2022 from Drake University. The information I'll be discussing today is my interpretation based upon the listed references at the end of this PowerPoint, and this is as of September 2021. A quick overview of what I will be discussing today is which patients are at risk for acute alcohol withdrawal, the typical timing of symptom onset and what those symptoms look like, the CWA scoring or symptom scoring of alcohol withdrawal symptoms, how to manage inpatient acute alcohol withdrawal, and then benzodiazepines and their place in therapy. So the patients who are at a highest risk for alcohol withdrawal are patients who consume a high quantity of alcohol and have for a long duration of time, and consume this alcohol at a regular frequency. This box to the right shows the DSM-5 criteria for alcohol withdrawal, which includes the cessation of alcohol use that has been heavy and prolonged. Those terms are not defined by specific number of drinks or specific duration. That is up for interpretation and may vary per patient. Typical symptom onset after a patient has stopped using alcohol: in the first 6 to 12 hours, they may experience insomnia, tremors and anxiety, some GI upset, nausea, vomiting, headache, palpitations or tachycardia, and then hypertension. Anywhere from 12 to 24 hours, this is where alcoholic hallucination comes in. So visual, auditory, or tactile hallucinations are possible. Moving further from cessation, 24 to 48 hours later is when withdrawal seizures would typically show up. These are usually generalized tonic-clonic seizures. And then 48 to 72 hours later and potentially beyond is when delirium tremens would show up, which is hallucinations, typically visual, disorientation, agitation, and diaphoresis, or that excessive sweating. This is what the typical presentation shows up as. However, patients may vary and not follow these specific time frames. So the CWA scoring, this is typically monitored frequently for patients. The CWA stands for Clinical Institute Withdrawal Assessment for Alcohol. So this scale is an indicator of how severe a patient's withdrawal may be. Each of these points are rated in severity on a 0 to 7 scale, except orientation, which is rated 0 to 4. Higher scores indicate more severe symptoms, with the exception of orientation as well, where if they're oriented times 4, they are fully oriented. CWA scoring is typically monitored every 1 to 4 hours in patients who have suspected severe withdrawal. If a patient's CWA score remains below 10 for 24 hours, then the frequency of monitoring may be reduced. The CWA scale is a standardized assessment that providers can access to determine the level of withdrawal that their patients are experiencing. Managing alcohol withdrawal inpatient and how we treat alcohol withdrawal starts with supportive care. This typically includes thiamine, which should be administered to patients who have poor nutritional status, malabsorption, or who have severe complications of withdrawal. IV or intramuscular thiamine is appropriate until the patient is able to take the medication orally. Thiamine should also be administered to any patient admitted to the intensive care units for alcohol withdrawal, just based on severity alone. Electrolyte management is another important aspect to help reduce seizure risk and reduce the risk of cardiac arrhythmias for patients. So patients should frequently have their electrolytes monitored, especially magnesium and phosphorus. Folic acid supplementation is recommended for patients who are critically ill because chronic alcohol use can lead to a depletion in folic acid, vitamin B6, and vitamin B12. This depletion is usually due to poor nutritional status, so replacing the folic acid and improving patient nutrition can help to reverse that. The first-line pharmacotherapy option for treatment of alcohol withdrawal is benzodiazepines. They decrease symptoms and decrease the seizure risk as well. Further into benzodiazepines, diazepam, lorazepam, and chlordiazepoxide are most frequently used in treating alcohol withdrawal. While there's no evidence showing superiority between agents, these longer-acting agents are often preferred because that duration contributes to a smoother course of withdrawal and a greater control over those breakthrough and rebound symptoms. This long-acting mechanism provides coverage for preventing the withdrawal seizures and delirium. A concern with long-acting benzodiazepines is the accumulation for patients who are older or who have decreased liver function, which can lead to oversedation or respiratory depression. So patients with these concerns, older patients or patients with poor liver function, are recommended to use drugs which have less hepatic metabolism, such as lorazepam. It provides less hepatic metabolism and also is an intermediate length of action, so it can be beneficial if liver function is unknown or poor at the time of benzodiazepine initiation. Anticonvulsants are alternative options for patients who are unable to use benzodiazepines due to contraindications or non-response. Gabapentin can be good for treating withdrawal when the clinicians are also interested in using it for ongoing treatment of alcohol use disorder. In terms of dosing of benzodiazepine, in terms of IV versus oral, oral is the preferred option unless the patient is unable to take an oral medication due to active seizures or any other reason. IV would be an option for these patients or those who need urgent administration of a benzodiazepine. The dosing regimen for benzodiazepines, symptom-triggered dosing is the preferred method for administration during alcohol withdrawal. It's often given when the CWA score is greater than 9 or greater than 12, depending on patient symptoms, and it may vary depending on the facility's particular protocol or the patient's severity risk. The symptom-triggered dosing allows doses to be individualized based on the patient needs and has shown to reduce the duration of treatment and inpatient length of stay compared to fixed dosing. The CWA ratings are done at a fixed schedule, and the drug doses are administered based upon that CWA result. A fixed dosing regimen or a scheduled dosing regimen, the set amount of medication is administered at a regular interval, and the dose amount, dose frequency, or both can be gradually tapered at a set schedule based upon patient response. This fixed dosing is easy to administer, but it can over or underestimate the amount of benzodiazepine that may be needed for particular patients and can lead to insufficient symptom control or oversedation. If prescribing a short-acting benzodiazepine, the fixed dosing regimen with a gradual taper may be appropriate to reduce the likelihood of breakthrough or rebound signs and symptoms. With both of these methods, there's an option to front-load a dose. The front-loading doses are recommended for patients who have a severe risk for alcohol withdrawal or have a CWA greater than 18. In these situations, a moderate to high dose of a long-acting benzodiazepine is administered to achieve more rapid control of symptoms, which can then be tapered down through the metabolism of the drug. Typically, diazepam and chlordiazepoxide are the preferred agents for front-loading methods. This is an example of a dosing regimen that uses chlordiazepoxide. So it goes through single dosing and then either the symptom-triggered or fixed dosing methods, as well as a front-loading example at the bottom. Thank you for listening today to this brief overview of alcohol withdrawal management in hospitalized patients. Again, all of the information today was based upon these resources and is my interpretation of the resources listed here. Thank you.